Thank you, Maureen. Thank you, everyone. It is true honor and pleasure to be with you today, and welcome everyone to this virtual celebration and discussion. The most important thing is that you get something out of it. The most important thing is that you get the feel, the taste, the tenor, the texture almost of where your medical school is, and I'll go through some of the ideas, some of the data, some of the stories, and all that good stuff. But what would help me tremendously is if you do ask questions. I can be interrupted, I can be slowed down, I can be redirected. I'm highly trainable. So please, let's do it together. Next slide. So one good thing that came out of the pandemic that we rethought and narrowed our focus. And we kept it reasonably simple and active. And our four main functions are listed here. We teach, we explore, we heal, and we serve. Next slide. I'm guessing that none of you are in this first photo of the first official graduating class, but some of you perhaps have been around and remember when the brutalist architecture of PWB and Moose Tower was fairly new. Next slide. The pandemic itself, as I said before, tightened our focus. This is really important because as we go through our mission, as we go through the functionality whereby we serve the community and the state, it's really important that we look at ourselves in a reflected light of that pandemic experience, and that we can elevate some of the things that happened in 2020 and 2019 and 2021, and emphasize the way we interact with the community as we serve both outstate Minnesota with RPAP and urban Minnesota with MetroPAP, and in many, many other ways, primarily through research and community health initiatives. Next slide. And now how you've seen it all. So looking through the prism of how difficult the pandemic has been for active physicians, you may be pleased to see that the enrollment, the number of applications that we have received, has dramatically increased, even more in Duluth than in Twin Cities. And that, I think, is a function of how inspired the community, students, have been by the tremendous work of the physicians in the crisis, and how they felt about the responsibility brought into lived experience and to action, and the impressive group that has applied to our medical school. Next slide. Just looking at the numbers doesn't tell the whole story of the, for each of the class. We currently have over 2,000 students and trainees, and I should also note that we could never had come through the pandemic so well without the incredible efforts of our residents and our fellows. Next slide. The last two match days were virtual. It's a little strange, but the downside, of course, of that is not to having all the students in one place to support and embrace and celebrate each other. But on the upside, it was wonderful to see all the babies or the parents and even pets walking across the screen, adding some warmth and some personal angle to the day. Next slide. As always, our match was high, and we matched incredibly well. We almost always do. And the map of the United States shows where all these trainees of ours have gone. But again, I'm going to park you back to the 117 in Minnesota. We have an incredible retention rate and stickiness of the state of Minnesota. New slide. I want to mention that the Duluth campus efforts over the past 20-some years were incredibly powerful to engage young students and get them interested in science and medicine. These are elementary students from Net Lake. I got to meet with them one year, and it's probably one of the most fun things I have done in the whole tenure at the University of Minnesota. At the end of the day, when we ask how many, and we make DNA, out of the little candy and so forth, and we have a lot of back and forth, and some of the questions are incredibly insightful. And at the end of the day, when we ask the students who would consider becoming a scientist or clinician, the majority of them raise their hands, and it's a great program. Next slide. It's just a part of the infrastructure in Duluth, however, that has created an architecture, permissive hierarchy, if you will, that ensures that Native American and Alaskan Native students get the experience in the lab or in the field, as you see on the right, to help them pursue whatever they want to do with their professional life. And this program is designed to give students attending local colleges support with their research experience. Next slide. Another part of the program is called Native Americans into Medicine, that specifically targets sophomores and juniors interested in pursuing health careers. And it's a 2-year program. They perform research, and in the last year, for example, they used the Strong Heart Study. That's the title of the study. And it's the largest epidemiologic study of cardiovascular disease in American Indians in the United States. Next slide. We are, of course, research university, and the research is strong focus of the medical school. And you can see that the amount of NIH funding has been increasing every year. Next slide. With COVID-19, we have seen a lot of new things. We have seen the ECMO that has been in news quite a bit, but what is less well known is that we developed a portable fit in the back of the SUV kind of model, and we have relationship with several metro medical systems that can deliver this equipment to the emergency rooms, where get the equipment to the emergency rooms or get the patient to be treated in the field, and then have this ECMobile, as we call it, a semi-truck size portable emergency vehicle that can go directly to the patient and get them hooked on the ECMO, and this way increase how far and how fast we can respond to patients in need outside of the metro area. Next slide. We were charged by the state to look into number of interests of the state of Minnesota. It was the Blue Ridge Commission of Governor Dayton that has put it in front of us. And we have created videos that you can see about all the 4 medical discovery teams that you are you see on the slide. There's a little link over there that Maureen perhaps can put in the chat so that you can keep it. It's called Where Discovery Creates Hope. And the only reason why I have this little November 6th over there, that's the day that it's the release date of the Rural and American Indian Health video. Next. The Memory Keepers, which is this one, focuses on dementia and improving care of people in Native American and rural communities. And Kristen Jacqueline, whom you see on the left, is the director. And Dr. Wayne Worry, pictured at right, leads the rural initiative. And of course, this year, we were able to put the experience and the skill set and exquisite way of the clinical team's performance into our hospitals and clinical centers and community clinics. Next. We created a new institute on infectious diseases. This is sort of under development. This is a reflection of the understanding that the COVID-19 is a starter pandemic, not the last one. This is the 3rd coronavirus pandemic this century alone, and we want to be ready for the next one. Next. We have also opened what we call Learning Health System Sciences Center. And this center focuses on using data to improve quickly clinical practice. It's a very basic way of how to get more patients' data into the clinical decision making, and also to analyze it in a way that the patient themselves can be decision makers around their health. That ultimately is the agency that we seek. Next. We serve, of course, especially the state and the citizens of Minnesota. I have been humbled and at awe multiple times during this COVID-19 pandemic and our response to this. But one or couple that I'm really proud of is the efforts of Dr. Sophie Ayohi that led a campus-wide effort to collect lab equipment and materials to set up a diagnostic testing lab and had it accredited within 10 days. That's just never happened. And it's my understanding that this team didn't sleep much at that time, but also they were able to present the university first, the surrounding community second, and then the state of Minnesota, along with our partnership with Mayo, with a workable, very deep and very broad testing program. Next. Another point of the medical school pride is our students, our medical students. They were unable to go to clinic. They were unable to get the hands-on experience at the beginning to have their rotation. So they channeled their energy into one of the greatest needs of early pandemic, which was, wait for it, childcare. And they were able to support this way our frontline clinicians. And this model was adopted across the whole United States. Next. In Duluth, we have also had a change in leadership. I have asked Dr. Riegel and Dr. Nalin to serve as interim co-regional campus deans, and we are seeking the new leader as we speak. Next. When people ask about the changes, how they occurred, and because of the pandemic, how we do things differently and so forth, the experience of being totally disrupted actually opened us to many new ideas. And I think that the future of medicine isn't so much that what we do, but how we do it. Next. For example, in the beginning of the pandemic, medical professionals came together around the world, and it was quite incredible how we passed on each other the information as we learned from another place. I still remember having these twice, 3 times, 4 times calls, and not as much Zooms. This was really more calls at the beginning with our colleagues in China and Lombardy and then in Seattle, and exchanging the information in real time. And one of the learning points there was the profound generosity of each other to share the research as quickly as possible and not really run to be the first to publish. Next. We also came together locally. The credit here goes to James Herford and his team at the Fairview Health System, and he obviously with us is co-leading the mHealth Fairview when the situation has been changing hour by hour. So we were, that was not my idea, so I can say it was brilliant, to repurpose a hospital into a COVID-only facility. This is the Bethesda. And this change has been, again, one of these things happened in 72 hours and totally changed the way we've been able to work together in one place on the challenge of the COVID-19 pathology that we didn't really know at the beginning how to handle. He couldn't know, nobody knew. And there were dramatic and rapid improvements to care. And it was very personal. All medicine is very personal, as you know, but it was personal for our CEO, Bevan Yu, for example, who was hospitalized in mid-March or so. And then 3 weeks later, his mother, and he was astonished himself and also how his mother was taken care of, how the academic medicine changed the care of the patients with COVID-19 in Bethesda Hospital. Next. We also have learned that if we all focused on the same thing, we can cut through the red tape like it's not even there. And we didn't cut any corners. So we didn't do anything that is obviously outside of the regulatory realm, but we got it done very quickly. And that was a sentiment from the state and regulatory agencies that I would like to hope that can continue. And in this way, we were able to start the clinical trials that you see on the right and really answer with data the questions that not just the state of Minnesota, but really the international public and community has been waiting for. Next. The three big takeaways from the pandemic are perhaps the virtual visits will never entirely replace in person, but will stay. People like them. There are some specialties like psychiatry and others that really found a niche in this realm. The second would be that the teams are critical, especially the interprofessional teams. Everybody contributes something that is of value and it's relevant. And third is that we have started, and I think we have advanced significantly, but we have still ways to go to improve access of everyone to healthcare across the state. Next. And one of the tools that will help improve access to the healthcare will be mediated by artificial intelligence. This is a way of handling data by computers, as you probably know, and it is possible, for example, to deconstruct a chest X-ray that would be available in smaller emergency rooms and smaller clinics, and when linked to the electronic medical record, we can apply this computer vision to the scan and have the data analyzed from that picture in a way that we can offer a probability with which this particular scan comes from somebody who has COVID-19 rather than, say, influenza or RSV or something completely different. And again, this improves the decision making, and it improves the quality of the care, and it improves the access, because these patients may or may not be in need of a transfer to Twin Cities, for example, can be taken care of locally. And that, I think, improves what we are ultimately after, which is to increase the value that we bring to our patients. Next. The Delta variant has completely changed the trajectory of the pandemic, but as we are still continue as of this morning, high ICU volumes and high hospital counts. Dr. Greg Bielman is leading these efforts on the hospital side. We are doing what we are supposed to be doing, which is taking care of our patients, and that has not changed in any way as we have walked through this. And it must be understood that we trained for this, for things like that. And for many of our team, this really was and is the finest hour. Next. So where are we now? That's obviously depends on how you look at this personally and societally and scientifically. We certainly have seen science polluted by politics in all of this, and there is a general knowledge that there are numerous sources of information, if you will, and what should not be forgotten is that the whole response to COVID-19 has been borderline miraculous, because never in the history of mankind we were able to generate the vaccine that is 95% effective in a span of less than 1 year, and have billions of doses of that vaccine delivered to patients. Next. So I suspect that you know a lot about the COVID-19, and perhaps some of the questions can be directed in that direction. Maureen, do we have any questions that I should stop and answer? Probably not.
No, not at this moment.
So let me update you on two programs that we are starting now, and I sometimes refer to them as the bookends of life. A couple of years ago, the Shriners Hospital, which is just up or down, whichever you look at it, down the road from the campus on the river, was for sale, and it seemed like a fantastic opportunity. We just have to decide what is the best match between the function and the place. Next. And we have, for a long time here at the university, done research on brain development and brain disorders. And this is between the medical school and College of Education on Human Development. And we certainly have used the ingenuity of our engineers and people from College of Design, and certainly, from community engagement. And so we put it all together and focused on what I would call developmental causes of disease. So if you want to affect the midlife mortality, which is people in their 30s and 40s that die of depression, suicide, obesity, and overall have just very difficult time to get over some of the addictions and some of the patterns of their lives and integrate in the society, the right time to intervene is several decades before that happens. And it so happens that in the first 1,000 days, for 3 years, there's enormous plasticity of the brain that can be either beneficial in all the learning that we know is happening in children that young, but also can be incredibly harmful if these children are exposed to what we call adverse childhood events. And the genius of the center is this Institute for Developing Brain is in the fact that you can influence the trajectory of somebody's development, even if she or he were exposed to these challenging circumstances in their very early life. Next. So we put together disciplines that matter to this. We put together everything from the magnetic resonance, which is one of the best in the world, to community engagement, to brain development, nutrition, childhood and adult psychiatry, psychology, and so forth, and build a great leadership team. Dr. Georgiev, who has done study about the nutrition in the early brain development, especially with iron deficiency anemia. Dr. Fair, that specializes in imaging the brain while it's active and how to harness the big data that can come out of these images. And Dr. Randolph, who happens to be both the neuroscientist and community organizer, and the only person I know that has 2 PhDs. And she is able to drive this and take the things from there. Next slide. What's different about this institute is how we work together, not what we do, but how we do this. And it is what others have, Stuart Kaufman, to be specific, called adjacent possible, which is you need to have the progress in a field or in any kind of endeavor, not skipping over certain stages, but you need to have this in this fertile, a little unstable, a little open territory between something that's very hierarchical and solid and something that is very entropic and very noisy and random in many ways. It's on that little area, on that boundary where most of the creativity happens. And what we have done at the Institute for Developing Brain is to take that permissive environment that we learn from others, from, say, Bell Labs, where they're like that, Cavendish Labs, were like that. I would think that probably Steve Jobs' Apple at the beginning was like that. And we have taken these 4 entities, the community, the MLFRE with James Hereford and his team, the College of Education and Human Development, of course, the parts of the medical school, and allowed this to not just collect the dots of brilliance, but really connect them in a way that can be channeled in a shared purpose and shared consciousness, which ultimately delivers better health to Minnesotans and actually internationally. Next slide. So on the other bookend of life, it is Geroscience. And one of our medical discovery teams, I should say, I'm sorry, I skipped. Go and see it. We are opening this on November 1. We have remodeled the whole facility. I remember the facility because I used to work in the ICU there when it was an orthopedic hospital, and I knew that it's beautiful. I knew the park is beautiful, the location is beautiful, the openness of it is beautiful. So go and if you can, go see it. Next slide. So the other bookend of life that I started to talk about is where we focus on Geroscience. And one of our medical discovery team called IBAM, this is represented here. It's an Institute for Biology of Aging and Metabolism, represented by Dr. Laura Nienhofer and Paul Robbins here, is focusing on how to enable the tissues of the body that naturally age to rebound and recover their ability to function. Dr. Pakala, who is the chair of the family medicine department, is working on a statewide initiative to train caregivers in how to deliver specific and specialized geriatric care. So there's a connection between the biology of senescence and the delivery of care that, again, I think we are uniquely poised to deliver for Minnesotans. And it is one of the most, next slide, most challenging and most meaningful interventions, I think, that can happen in the science and in society today, because every day of this decade, 11,000 people in the United States become 65-year-olds. These are the baby boomers, of course. And 7 out of 9 of them will end up in the long-term facility. And we are not able to really provide the high-quality care just because of the sheer magnitude of the challenge and the somewhat ill-suited business model of the healthcare in the United States. So the way to do this is very similar conceptually to the Institute for Developing Brain that I introduced you a while ago, which is we all know that the code, the DNA, stays stable. What is not stable with age is how well you can repair some of the gaps in when the cells replicate. So the reader cells, the reader systems that would correct these errors are degrading, are less of functional over time. And then the cells that are senescent, they are not really quiescent. They are not really going away. They are sitting there, and they sort of misdirect their functionality to secreting proteins that is, it's called senescent protein phenotype, that trigger the immune system to respond inappropriately by increased inflammation. And this increased inflammation, that is really what's behind the biological clock as compared to chronological clock. We know that some people, everybody has the same chronological clock, right? This is the calendar. But people age at different rates, and their tissues age at different rates. And the different rates of aging seems to be proportionate, closely related to the amount of inflammation and the kind of inflammation that the tissues and the organisms, people, develop. And the beauty of this biology and the beauty of understanding is that you can do something about it. You can take out these senescent cells out of the tissues, like you would take, if you have a crate of apples and one is rotten, you can take that apple out and the rest of the apples are fine. If you don't, it's going to spread around that apple. And we have drugs now, medications called senolytics, and that's where Dr. Niedenhofer and Dr. Robbins are pioneers internationally. That's why we hired them here, that can do this and take out the senescent cells. And why is this important? It's not some kind of a beauty contest, or it's not some kind of a even physical alone contest, even though freedom from disability and disease is a paramount one in our minds. It is more than almost all of the conditions that are associated with ill health in older adults, being this cancer, stroke, myocardial infarction, seem all of them to be related to this inflammation. Dementia is another one that is related to that. So it seems as if you can take the process that leads to these various ailments of older adulthood and stop it from producing these ailments before they even start. So by the same symmetry that I described to you in the first 1,000 days, the first 3 years of age, where you can prevent that maladaptation of adulthood in midlife, the same way you perhaps can prevent the multitude of morbidities in older adulthood by intervening 10 years ahead or 15 years ahead by relatively simple maneuver of taking out these cells, of purging the tissues of the senescent cells, and allowing the homeostatic mechanisms of our body to reconstitute the functionality if as much as possible. Next slide. So aging and aging well is critically important for both the clinical care, but also I would argue for the societal well-being. And the goal here is really not increasing the lifespan, even though it might, but really the quality of life, the health span, if you will. So I'm an oncologist, and if by some magic you can stop all the cancer from happening, you would get 2 years. 2 years, that's it, extra in the collective lifespan. If you were to able to do the same for vascular events, strokes and say myocardial infarctions, aneurysms, and so forth, you would get 3 years. That's not that much if you think about this. If you think about the magnitude of the effort and business that gets into treatment of these conditions. Next. And my questions. So the floor is yours. Ask me anything and everything. Thank you.
Thank you, Dr. Tolar. Everyone should feel free to type their questions in the Q&A. I will start off with one that was submitted during the registration process. I wonder if you could talk about the diversity, equity, and inclusion initiatives that are happening at the medical school.
Of course, we are very proud of being able to be active in this. So first of all, diversity in my reading of history, not just medicine and society and not just Minnesota, is that almost everything that has been of value in increased understanding of who we are internally, externally, is almost everything has been brought into the fold by somebody who was coming from a minority group or different language, different lands. And the reason for that is very simple, which is that my understanding is that no single brain will contain all the information that's relevant to a particular challenge. So what I have instructed in both the admissions and clinical care and research teams is to work as a team, so that people provide, sometimes knowingly and sometimes unknowingly, because the lived experience that some people bring, that we all bring to everything we do, may be not verbalized, but is still present there. So this accumulated knowledge of different cultures, different places, different ages, different walks of life is still there when the people contribute. And that's why diversity is really the basis of excellence. Diversity is really the basis of advance, and building a medical school and building a practice that enables that is permissive environment for that kind of ambition is has been the plan for many years now. And I am pleased to report that it was, I think, 3 years ago that we matriculated more women for the first time than men in our class. And we, as you measure the diversity and multicultural background of our students, it was almost 50% this year that were multicultural. It's quite a distance from where we were even 10 years ago. Thank you for the question.
And it looks like Dr. Ruzica asks, can you remove these senescent cells from the brain? Is the blood-brain barrier an obstacle?
So this is wonderful. This gives me an opportunity also to pronounce his surname differently, because Růžička is a classic Czech name. It doesn't have all the, it's written slightly different, but it means small rose. And Dr. Růžička, of course, is right. The brain can be accessed by senolytics. The blood, these are small molecules typically, so they do get across the blood-brain barrier as well. Not all of them, but there are selected ones that do. And in fact, dementia is one of the targets of the senolytics. There is also indirect way of targeting brain in senescence, and that is decreasing the amount of inflammation that's systemic. So what I mean by that is that the inflamed blood-brain barrier, for example, and I have been a part of my clinical practice. I'm a bone marrow transplant physician, and I work with some of the genetic disorders, and some of them are the dementias or neurodegenerations, rather, of early life, like leukodystrophies, metachromatic leukodystrophy, globoid leukodystrophy, adrenal leukodystrophy, and so forth. And they are all, to a different degree, inflammatory conditions. So the possibility that you will decrease the systemic inflammation will indirectly affect the brain and the blood-brain barrier as well.
Thank you. Christina Piper Bigelow, Dr. Bigelow from the class of 1985, commented that her graduation class had about 60% women. Pearl Rosenberg was the assistant dean at that time and pushed for more female representation. And this dovetails nicely into a question that was also asked during the registration process. How has the increasing portion of women in the classes, how has that changed the profession, in your opinion?
Oh, profoundly, profoundly. It's a, so let me answer this in a larger way. We are training physicians now for a different kind of healthcare and different kind of medicine. I think that when I went to medical school, this would be 1980s, 84. The focus was mostly on being able to memorize a lot of things, being able to stand up and have a oral disposition of the argument and being able to defend in front of the colloquium of the professors what you learn. And I'm not saying that this was a bad idea. You know, it's sort of popular now to dismiss all that. I don't think so. I think that I learned, even though I didn't like that very much at the time, that's probably true. But it served me. It served me very well. These two traits that I learned in the medical school. So then we went through a couple of decades where the 1984, in fact, was the year that many of you would remember, because it was a memorable year, because you had the first PC, that was the first Macintosh. It was the year when the first Hewlett-Packard printer was introduced, the jet printer, and the year when the first mobile phone, the Motorola's, were introduced. And it's almost impossible for some people, like my children, to imagine that there was a time that this did not exist. Well, what that started was a kind of medicine that we are having right now, which is a lot of computer time, and it's sometimes necessary to remind my students and residents and fellow that you don't make diagnoses from the screen, that you don't make assessment and guide care from the electronic medical record, that you really need to go there and sit down or stand and examine your patient, speak with the patient, talk to her family and so forth. And partly because of the nature of the business of healthcare, which some call healthcare industrial complex, not incorrectly, is that it has taken clinicians away from the patients. So now we are turning this, and the wave that I see is that by demand of the patients, which is very appropriate, and the community, they want a patient-centered care. They want the healthcare being about them. They won't be the customers, not like what we have now. Now the customers are the insurance companies, not even the clinicians, not even the patients. And that needs to change. The billing, which really is the electronic health record that we have now, is built for billing, not really for communication and decision making. Now that needs to change as well. So what's going to happen is that we will look for clinicians in our admission class that have high ability to connect with each other, have deep wells of empathy, have propensity to work in teams, have ability to focus on the difference between the human and artificial intelligence, which should be symbiotic. And I would argue that my female colleagues, clinicians, are especially gifted in that area. It just changes the. So that's one part. The second part is that the truism, of course, is that approximately half of our patients are women, and it's really important that they see that the same proportionality is reflected in the clinical teams that serve them. And lastly, I have seen more ability to, let's put it this way. I've seen much more openness in the mixed gender teams than all male or all female teams. And I think that if we are on a pathway of, which we are, of changing the healthcare, we really need to have diversity of this kind.
Great, thank you so much. Dr. Jim Hart asks, how are you rebuilding primary care?
Well, that's a that's good to hear from Dr. Hart. Couple things are going to be extremely different. The primary care is almost a misnomer, I think, because it somehow suggests that it's primary, it's all happening there. It somehow suggests that it is the sort of a convening function, of where we are. And it has, I think, positioned us poorly in the preventative care. And that's, all the primary care physicians I know, all the family medicine physicians I know, they are close to heroes, because what they do is, day in and day out, is that they are trying to be simultaneously a doctor, a nurse, a sort of a coordinator of care, getting all the pre-authorizations, getting all the referrals, so being on the phone quite a bit, and the sheer magnitude of these multifunctionality again departs from the patient. So what I think is going to happen is that first of all, that we will need many more primary care physicians. We will rely on them for things that we should rely on them, because they are so good at what they do. They know the family, they know the community, they know things that for the specialist is difficult to really assess in the real time of a clinic visit. And we will reposition the healthcare to preventative, and the whole field will change from what we have now, which can be called a rescue care system. There's nothing malign in it, but we essentially wait until people have a stroke or a MI or cancer, and that's not necessary. We already have data that would position us very well with our patients to recognize the patterns that are at the very beginning, mostly subclinical, but beginning of that trajectory that leads to this complication, that leads to this kind of disease, and intervene at the time when there is, for all obvious things, the people are still in full health. And I think that rebuilding primary care around that is going to be a key to the success in the new level of healthcare. I will also say two other aspects of primary care that are unique and fundamentally key to our success as healthcare professionals. One is behavioral health, the ability to understand the ramifications of the mental state and how this integrates into the physical and mental well-being. And the second one is what slightly was referred to before, the disparities of care. How we gonna equalize the opportunity of people getting the same healthcare across the, let's say, first the territory of the state of Minnesota, but then truly across the United States.
Thank you. Finally, Lindsay is going to unmute Dr. Ruzicka so he can comment on your pronunciation of his name.
Yes.
Dobrý den.
Dobrý den.
Jak se daří?
Daří se výborně. To je parádní, že někdo mluví česky taky.
Jakub Tolář, ne?
Tolar, as in, yeah. Jakub Tolar, ano. A Petr Růžička, to je krásný český jméno.
No ano, já jsem si to myslel.
I don't think that very many people can understand what we are talking about, but it's a very genuine exchange in and I have to commend Dr. Růžička, accentless Czech, which is obviously the place of my origin, and English. English is my not second language, but I think a third or fourth language. So this is very kind of you, Dr. Růžička, to raise your Czech voice.
Well, of course, but I was also interested in the neurosciences. How are you building the neuroscience? And since I'm a pediatric neurosurgeon.
Oh, fantastic. So the neurosciences is one of the 3 priorities for the school and practice. We have been fortunate in, so you as neurosurgeon may know that I hired about 3-4 years ago a new chair of neurosurgery here, Dr. Chen, and he's one of the physician scientists, which is helpful in an academic neurosurgery, and he is mostly a skull-based and mostly cancer surgeon. The department is focused on the linking of the basic science and sometimes devices to the surgical realm. Our neurology department is very much oriented around deep brain stimulation. And as you of course know, but for others, it's not just the Parkinson's disease. It's sort of like a pacemaker for the brain. And it can be extremely helpful when placed correctly and monitored well, can be extremely helpful in Parkinson's disease, but also in other conditions such as epilepsy or obsessive
tremor too.
Yep, tremors, and even perhaps in people with obesity and addiction. So we are working on some of that as well. Our neuroscience department is one of the best in the United States, and one of the medical discovery teams is on addiction. And so we are building a lot around the fact that we have one of the best imaging centers in the world. There's the Center for Magnetic Resonance, and the Institute for Developing Brain that I showed you is, we have a 3 Tesla magnet there, but we have a 10.5 in the center. We were one of the first who were able to constitute what's called adult connectome, whereby we can map the circuits in the connectivity, the synapses and cells in the brain, in the living brain, in the patient. We are probably the first ones that put together teenage connectome, and definitely the first one to put together the baby connectome. So we are trying to your question, Dr. Růžička, we are trying to mine the profitable niches, profitable in a knowledge epistemic way of neuroscience, neurosurgery, and neurology, and combine it with psychiatry, psychology, and the community engagement. So it's an ambitious undertaking, but it's an ambitious realism, because we truly have the groups that are capable of agile thinking and get things done, which is really the mantra of my teams. Thank you for the questions, and thank you for the Czech interlude.
Well, that's good to hear.
Thank you.
I did my neurosurgery there.
All right.
Well, thank you so much, Dr. Tolar. We did actually have another comment from Dr. Bigelow. She said that she accompanies her father, who is a 97-year-old World War II veteran, to the Czech Republic every May for Pilsen's celebrations of VE Day. She says it's nice to hear Czech again, since she has not been able to go the past 2 years. So she thanks you for sharing your conversation.
This is wonderful. Thank you so much. I had no idea, because there are like, 10 million Czechs in the world, And I got 2 in the same forum. So this is wonderful. Give my best to your father, and I'm very grateful for his service.
Thank you. So thank you so much, Dr. Tolar, for sharing the incredible work that's happening at the medical school. There's so much to be proud of. And I think as alumni, they can be very proud of what's happening here and their part in it. I want to extend my thanks to all of our participants today as well, and remind you that there are other alumni celebration webinars happening this month. I want to call particular attention to the webinar next Wednesday at 1 p.m. Central. We will have our second MEDX Alumni Showcase, where Dr. Carlos Gutierrez, Dr. Angela Cotty-Gepford, and Dr. Carol Nelson will share stories of their work that they've done since graduating from the medical school. So check out the Alumni Celebration website for the rest of the webinars coming up this month. And hopefully we will see you again on another webinar. Thank you all so much.